what's exciting her to do that, or making her do that, because she is a patient and she believes in the operation and trying to increase the awareness so the patient who had malrotation don't have to suffer, and also educate the medical community with the new operation that helping hundreds of patients, children and adults, and protecting them from losing their intestine, from the twisting of the bowel, and the death and the loss of the bowel that sometimes change their life forever. And some of them may require even transplantation or live on TBN for the rest of their life. That's mostly in the children and small percentage in the adults. But most of the adults suffer from chronic symptoms that most of physicians don't believe it's related to malrotation, and they keep them suffering and, labeling them as they have psychiatric disorders or just to get out of my face and live your life, something like that. The disorder or the congenital anomaly, when you have it, you were born with it. And it happens usually in weeks 4 to 10 when the embryo develop in utero or in the womb, and whoever had malrotation was born with it. And the first attention to the malrotation happened in the 1930s when Professor Ladd found some kids that they have bowel obstruction, or they about to develop gangrene of their bowel, and with a band named as Ladd bands that obstructing the upper part of their intestine, and they vomit all the time. That's what Ladd procedure came to play in 1936. But not every patient with malrotation will have the Ladd bands. They have chronic symptoms, and they can twist their bowel up to 64 years of age. Symptoms could appear at any time from childhood until adults. But we have to keep in mind that most of these patients were born with the disorder and they didn't know what is normal. So what they're suffering from, like a fussy child, the mother would say, every now and then have nausea or vomiting, abdominal cramps, and they explain it for other things, not knowing that the child has malrotation. And when things progress, then when they go and the adults, they seek some medical attention, and if the pediatrician or the physician have a high index of suspicion, they start working them up.
I guess there's a difference between, an upset stomach and constant pain. So how would I tell my pediatrician or my general family doctor, this is not just that?
It's very simple. When the physician, the pediatrician, the parents or the physician, if the child or the newborn baby or child or adolescent or young adult or old patients, if there is high index of suspicion or have symptoms, nausea, vomiting, bloating, constipation alternating with diarrhea, they should put in consideration the malrotation or the intestinal malrotation. How to diagnose it? Very simple, with X-ray. With X-ray, with a contrast or a CAT scan. And nowadays, in the old days, there was no CAT scans, there was not all MRI, all these fancy tests. Then they used to do it to plain X-ray, or they ask the child or the adult to drink some contrast and take films. And it's exactly the same. Now we have no excuse. As physicians in the medical community, we have all the tools to make an accurate diagnosis of malrotation. And what make it more sad is the physician had a high index of suspicion, make the diagnosis with the abdominal CAT scan or gastrograph and follow through or ultrasound in the kids. And despite that, you tell the patient that your symptoms has nothing to do with malrotation. And what's driving me crazy?
Did you know that Taylor was going to do this?
No, actually, it was a very surprise for me. And as a matter of fact, she text messaged me, and she didn't know that I had COVID at the time, coming back from the Middle East, working in my charity hospital. And but I didn't know if she knew now or not. But I was very happy for her that it indicates to you that how helpful this operation is for her to be excited, go back to her normal life, back to work. That is a testimony of the success of the operation for almost all of them. And we just when a medical community and the most of the public to know that the malrotation means that the intestine did not rotate in a certain way to be like everybody else. So the colon in a certain area, the intestine is in a certain area, the upper part of the intestine, we call it the duodenum in the left side. And all of this are attached like when you have nails or tape. Taping, all these structures are taped with a structure called mesentery. And in these patients, something happened in utero, and this mesentery or this tape did not develop to keep the intestine and colon in a normal position. And that's what put them at very high risk of the twist. So the intestine freely mobile, not attached with the tape into the retroperitoneum or the posterior wall of the abdomen. So it moves all the time and give you the noise that we all hear and like, okay? Because you may need to know that the intestine, a piece of healthy piece of intestine is more important to a human being than any quantity of brain, believe me. And there is a connection between the gut and the brain. Having said that, the malrotation is due to the poor development of the mesentery, which I said the tape that keep the intestine in its place, and also defect in the enteric nervous system, which is the brain of the gut that developed during the same time in the week 4 to 10 in utero. And this brain of the gut is always connected with the brain, with our own central brain, and they're communicating with each other. That's why this patient, when they have a lot of problem, it definitely affects their well-being. And having said that, another problem with the malrotation is about 1/3 of these patients have a dysmotility. The intestine doesn't move normally and lazy, particularly the large bowel. So they develop the severe constipation, they cannot tolerate food, the stomach doesn't contract well, okay? So with this new operation, we take in serious consideration the piece of the large bowel that is not functioning well, we take it out. Because when you have problem downstream, you will always have a problem upstream. And that's why they start eating and drinking. And particularly in the adult and adolescent, they develop what I called it congenital malrotation syndrome. Nausea, vomiting, abdominal pain, bloating, like a pregnant woman, to the extent some of the adolescents or young adult female, when I interviewed them, they said their parents sometimes thought, some of them thought that they're pregnant, and they did a pregnancy test on them, which is really put them under a lot of stress for a disorder that they have nothing to do with it. And they always tell them that blame your mom. Yeah, whatever it is. And the patient have symptoms cannot be explained by any obvious disease that the physician are aware of, and they have no explanation for the symptoms. Please, for the physician, please trust your patients, believe in them. Put the congenital malrotation as a part of the diagnostic provisional diagnosis or initial diagnosis. Do the x-rays and pictures and films that confirm or exclude the diagnosis. And if they have the disorder, they must be treated. And there is no medical treatment for it because it's an anatomical abnormality. There is no drugs can treat it. You have to correct the malrotation in the right way, not with the old fashioned that was in the past and was not Professor Ladd's issue. He saved a lot of lives and kids, but those whose life was saved early on, they continue to develop symptoms even after the Ladd procedure, as you can see in the paper we published in October, and the complete correction of the malrotation, put everything where it belongs and fix it like all of us. Whatever failed to develop in the embryo, we do it now surgically so we can help the patient to protect them from losing their gut and to relieve their symptoms. And I'm actually launching a campaign among a pediatric surgeon and pediatrician. And you can see this in a recent publication in the Journal of Pediatric Surgery, that I'm willing to help as many pediatric surgeons as I can to learn how to do this very simple procedure. As a matter of fact, one of the pediatric surgeon in Spain, did the first correction of the malrotation the way we describe it at the Cleveland Clinic in last October, and the patient is doing well. And this is actually the first case in Spain. Of course, I did many patients in the Middle East when I go for my charity hospital. And I hope that all pediatric surgeon can hear you, can hear the voice of all these patients. And when you make a diagnosis of malrotation, then it needs to be surgically corrected. And I hope within the next year or so, we have videos on the website, in the YouTube. We have a illustration of how the malrotation develop in utero, and this all valuable information that pediatrician and pediatric surgeon should look into it, and are available 24/7 to help anybody who is any pediatrician or pediatric surgeon that willing to learn the procedure and help their patients. They don't have to come to the Cleveland Clinic. This is not an advertisement protocol or program. We want to help people where they live, and to make the procedure the standard of care for all these patients who have malrotation with even and without symptoms. So protect them from losing the gut from the twist, even at 50 years or 60 years of age.